Good day. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology, and I'd like to welcome you all to our webinar series entitled Medical and Public Health Considerations of COVID-19. Today we're going to be having a feature presentation on the do's and don'ts of antibody testing policy and practice, and this will be followed by an update from Nepal in the context of COVID-19. Next slide. I'd like to thank our webinar partners. Next slide. All the webinars are recorded and posted to the ACMT website. You'll receive a notification approximately 48 hours once this is posted. You can see this webinar as well as any of our past webinars at the website acmt.net/COVID-19web. And any questions or suggestions about the series can be emailed to us at info@acmt.net. Next slide. There will be a Q&A toward the end of the session today. You can please type in your Q&A questions either into the Q&A box or the chat function on the WebEx. And for those of you who are listening in on Facebook Live or YouTube, you can chat in questions as well. Next slide. None of our speakers have any conflicts of interest to disclose. Next slide. I'd like to thank my co-moderator, Dr. Ziad Kazi. Dr. Kazi is a member of the Board of Directors of the American College of Medical Toxicology and past and president of the Middle Eastern and North African Clinical Toxicology Association. Next slide. Well, I'm delighted to introduce our plenary speaker today on a very important topic. Dr. Gigi Gronvall is the Senior Scholar at the Johns Hopkins Center for Health Security and Associate Professor in the Department of Environmental Health and Engineering at the Johns Hopkins Bloomberg School of Public Health. She is also an immunologist by training. Today she will discuss a very important topic regarding the regulatory, policy, and scientific challenges in antibody testing for SARS-CoV-2. Dr. Gronvall.
Thank you so much for having me. And thanks for flipping the slide. So yes, I'm delighted to be here today to talk to you about antibody testing. And it's now it's a very fast-moving field with lots of new changes every day. So I expect there'll be questions, but I will start off with an overview at a higher level in hopes that we will have time to go through questions. So a lot of the work that I'm going to talk about is gone into a lot more detail in two reports that that my colleagues in the Center for Health Security put out into the world. One was focused just on antibody testing. It was a little bit earlier on in April, and talking about there was a lot of challenges with the FDA at that time. I'll get into that in a minute. And then following on that, a lot of the questions about antibody testing were, we started to see lots of big sero surveys come out, and there were some significant flaws in the way that those surveys were done. And so we thought we would put out a best practices and explaining why and how sero surveys can be done and what kind of value you get from them, especially when they're done correctly. Okay, so I'll get into more of these, but these two reports have a lot more detail of what I'm going to talk about. So just to start off, what is serology testing or antibody testing? It provides lots of important information. The tests are blood tests to detect not a current SARS infection, although it could do that, but it's to detect your immune response to SARS-CoV-2. So because of this, you're able to measure, detect past infection. And for lots of, for many people, they were unable to get diagnostic tests, still unable to get diagnostic tests, but that's another topic for another webinar, to see if they're currently infected. So this provides you more of a historical account of whether somebody had COVID in their past. There are a variety of different tests. Some of them test for IgM, which is one of the types of antibodies that's more early onset. and then IgG, which is much more durable for all infections, but in this one as well. And so most of the tests that are most reliable look for IgG. And it's possible IgA is also found, but I don't believe there are tests that are looking for that right now that are on the market. So what is the value of these tests? On a population level, they are super valuable because you can, if you do big surveys, you can determine the true case fatality rate. With SARS-CoV-2, we've got a lot of asymptomatic infections, and so being able to determine that denominator is very important. You can, doing those types of surveys, you can measure the effect of different public health mitigation measures that you have in place, whether things are going in the right direction, whether there are populations that you are missing in your public health messaging, and where there are hotspots. So seroprevalence studies are really important. Serology testing is very important to capture all people, even who may also be asymptomatic. And a lot of people, as I mentioned before, do not have access to diagnostic testing. If we had robust contact tracing, so other nations have used serology tests to fill in gaps that were left by their contact tracing efforts, basically to solve some epidemiological mysteries that they were encountering to make sure that they got everybody. But there are limits of these tests. So serology tests alone, just based on our knowledge so far, cannot tell if a person is immune to reinfection. What they can tell you is that somebody, if the test is accurate, they can tell you that somebody had the infection. We do not know yet what levels or if they are important, the longevity of the antibodies that are necessary for protective immunity to SARS-CoV-2. We only have experienced this virus for the 8 months that we have, and up to this point, it appears that that people are, even though I'll get into the whole antibody waning stuff that you may have heard in the news in a little bit, but so far people seem to be developing and generating antibodies to infection. But and reinfection appears rare, very rare, if at all. It's been not documented much in the scientific literature. So so right now it tells you it's exposed, but we don't know what is important about the antibodies as far as protection. We can't tell from the serology test whether somebody has developed memory cells that might be important, or whether they had antibodies to related animal coronaviruses that might give them some protection. This all makes it very complicated for individuals. I mentioned all the benefits for sero studies, but when it comes to individual decision making, it's fraught because we don't know if somebody had COVID, whether they will continue to not be able to be reinfected in the future. We just don't know. And does the presence of antibodies, is there a level at which they have protection? And if it dips below that they will no longer have protection? We don't know that either. So there was a lot going on when it came to how antibody tests entered the marketplace. There was, at the time, the political climate was such that there was a lot of hope that these tests would allow the opening of the economy, that, you know, if it turns out a lot of people have antibodies, they're the ones that can go to work. They can have immunity certificates or immunity passports, and they can be released from physical distancing. And there was a lot of hope on that, and it wasn't just in the U.S., it was a lot of places in the world that looked into immunity certificates of one kind or another, and antibody testing was part of that. The reality became more complicated and for a variety of reasons. Some of it is scientific, that we just don't know if the antibodies leads to protection, but it also, there were some regulatory issues as well. So the FDA basically had a very light touch on the regulatory aspects of antibody tests, probably in reaction to the shortages of diagnostic tests, and did not require much data to be submitted or any data to be submitted to the FDA before marketing. And so companies were able to, as long as they were not used to diagnose infections, they could market these antibody tests. And this led to over 200 antibody test manufacturers entering the marketplace with claims with self-validated testing, and sometimes, independent validation showed a different story than what the company claimed. So, so even though there's that whole aspect of fraud, and there were a lot of tests that just weren't as good as they were claimed to be based on just the number of samples that they had or how they did the testing internally. It was a bit of a mess, and it's gotten better. The FDA has reined in that and set thresholds for what tests are allowed, but it's still challenging. And part of it is it's always going to be challenging because a test has to have high sensitivity. So to capture the cases, to capture the people who have antibodies, and high specificity to rule out once people who have, I'll get into the sensitivity and specificity, to present false negatives and positives. So if you have a high sensitive, like a 99% sensitive test, you have a 1% probability of false negatives. If you have a 99% specific, a test with 99% specificity is 1% probability of false positives. So all of those false positives and false negatives are much easier to deal with when you're dealing with a population level. When it's your personal taking a test, that becomes much more challenging. So under pressure, the FDA is now doing independent validation of these tests, which is run just because of the laboratory setup at the National Cancer Institute. And they are working through some of these tests, but they're still not highlighted and publicly obvious which tests have been independently validated. So this gets into the sensitivity and specificity, so you can see how the numbers shake out. And this is a huge public information challenge when it comes to antibody tests, which are in huge demand. On a population level, you can deal with these kinds of false positives and false negatives and work it into your math, but for an individual, it's a lot more challenging, and that 5% adds up. Not to get into more statistics, but the prevalence of disease also makes a big difference when it comes to the accuracy of these tests. So I'll give you one example. So this is about positive predictive value. One test that has emergency use authorization is the SELEX test, and it's got decent sensitivity and specificity. But for it also depends not just on the sensitivity and specificity, it depends on the prevalence of disease in the area that you are. So if there's 5% seroprevalence of SARS-CoV-2 and you get an antibody test in that area, a positive result would only have a 47% probability. It would have a 47% probability of being inaccurate. So it's not a coin toss, but it's really close to it. And so how for other diseases, when you have this kind of situation where you have low prevalence of disease and you are trying to get an accurate result from an antibody test, for example, for HIV/AIDS, you do sequential testing. you don't just rely on one test to give you that answer that you definitely have HIV, right? So you take multiple tests in a row, and so that's that's what you would do. But right now we don't have a clear medical decision that follows getting this test. So if you have a positive antibody result, that doesn't lead to a next step medically. And so for most insurance companies, they're not picking up the tab on this. And so, people, to get that kind of accurate result, somebody would have to spend $1,000 to get 3 tests in a row to get a definitive result for antibodies. So here are just the different serology test types. There are 3 different. There's 3 different approaches. They're more rigorous than others. The rapid diagnostic test just takes not too long, in the order of minutes. It tends to be less accurate, as you would expect. And then ELISA is probably the most common, and it requires blood draw, but it can also tell you how the level of antibody that you have. So if it turns out that we know at some point that you need to have a certain titer, then this test will be helpful. And then the gold standard is neutralization assay, and that will help determine if the antibodies you have are neutralizing antibodies versus just antibodies that can stick to the virus. So these are 3 different approaches, but right now what happens next is still in flux for all of them. For the last several months, we've been working to track the development of these tests and what's gone on with them. So we have on our website all of the tests that have emergency use authorization, and whatever data that we can find on the specificity and sensitivity of each test. And we've done this we also have this for the diagnostic tests. I will tell you that it's just not transparent or prominently displayed anywhere to any consumer, as far as I've heard, when people go get antibody tests, that what kind of tests they're getting and what kind of information they have about it. And for many people, if you hear that a test is 92% specific, that sounds like it's a low A, right? It's not. It doesn't translate into the statistics of it, and so that's a big problem. And people will make decisions based upon the test results that they get. So it's very it's fraught because there really is no change that you should have after even if you know you've had it, because we don't know what that necessarily means. So anyway, if you're interested, we have a list of these tests that we update just to keep track of what's going on and what the FDA has put out about it. So our recommendations for what should be done, validation is extremely important for these tests. It should be very obvious when you go to the FDA website which tests have been independently validated. We only noticed that validation information was making its way into the package inserts, and I don't know how many people really read the package inserts, but we've been doing this, so we noticed that some of the validation stuff was making its way in there, but I don't think that most people are noticing that. But it should be prominently displayed. There should be testing guidance for individuals, because for most people it will be a waste of money, especially until we learn more. And zero surveys are, of course, really important. The CDC is starting to release the results of the ones that they are coordinating, but we need to have longer-term longitudinal studies to be able to track what happens, especially when it comes to long-term effects. We also recommended that because there are a lot of serosurveys that were done poorly, like they didn't prioritize random sampling, which is important for the serosurveys, that there be a site similar to clinicaltrials.gov, but for serosurveys and also observational studies, because this information is important and needs to be more broadly shared. And just to emphasize, don't use these things for immunity passports because there's we just don't know how long immunity will last and if people have immunity and if antibodies are important to that. So antibody levels and the waning stories. So there's lots of data that comes out all the time right now. I mean, it's truly the most amazing part of what is otherwise in every other way a terrible epidemic, a terrible experience. Just how amazing the science has moved, and how collaborative and how open much of the science has been. But there are studies all the time. The stories that you hear about the antibody levels waning have been a little bit overemphasized because you do expect IgG to the levels to go down over time, but the levels are the decline is not as steep as the newspaper would suggest, and we don't know if that is if the antibody levels, whether we are seeing memory cells that are being produced, we don't know. And then there's the role of T cells in COVID infections. So T cell responses are a lot harder to measure than antibodies. And so we're seeing, some papers that are going into the important role that CD4 and CD8 T cells may have in immunity. Or at least the immunity that we're seeing so far. And so it looks like our immune response to SARS-CoV-2 is not just, it's not just in one immunological bucket, it's multifactorial. What is the future of antibody testing? I mentioned that, right now, there's no priority in doing the sequential testing to be able to know if you definitely had COVID in the past. But that could change, especially as we're seeing different problems that people may have as a result of being infected that are longer term. It may become important in the future to know if somebody has a history of COVID infection. It may be important for vaccine prioritization. If we know that people who have had it have durable immunity, that would put them at the back of the line to get a vaccine. So that would be another important aspect for antibody testing. There may be some vaccines that are preferable to others if somebody has already had it. And so that'll be another reason why antibody testing could be important. There's still a lot to learn about this disease, and so that's the story about antibody testing, and I look forward to hearing about Nepal and then later about your questions. Thank you.
Thank you very much, Dr. Gronvall. Thank you very much, Dr. Gronvall. This was a very informative presentation. I know you've answered many questions that I've had about these antibodies. I personally have been tested twice, and I've been negative twice to my dismay. You've explained a lot about this important test and the room for improvement as the science improves as well. Our next presentation is from Dr. Ramu Kharel. Dr. Ramu Kharel is currently a Global Emergency Medicine Fellow in the Department of Emergency Medicine at Brown University in Providence, Rhode Island. Dr. Kharel completed emergency medicine residency at Emory University and is a founder of the Health Advancement Program to Serve All, HAPSA, which is a nonprofit organization that's done a lot of work in Nepal. And he actually moved to the U.S. from Nepal at the age of 13 and has maintained strong relationships in Nepal in the areas of public health and emergency medicine. Dr. Kharel, we look forward to your update about the Nepal in the context of COVID-19.
Thank you, Dr. Kazi and ACMT for having me, and Dr. Gronvall for a really, really great presentation. Really enjoyed that. So I look forward to talking about Nepal for the next 10 to 15 minutes. What we'll discuss is we'll just discuss Nepal as a country and where it stands currently, and then the COVID updates from Nepal, and then we'll discuss unique challenges that Nepal has been facing because of its social and political context due to COVID-19. And we'll definitely touch up on the RDT testing and antibody testing and how that has been utilized in Nepal. So this is Nepal. It's a very small country that lies between two giants, China and India. And Nepal is, when you think about geographical size, it's half the size of Texas, but it has the population of Texas, about 30 million. It's a fairly young country. It has, the average age is 24.5 years. Majority of Nepali people live in rural areas, around 80%. The health system is quite weak. The physician density is around 0.6 to 0.75 per 1,000 people. That's very small. There are only 1,500 ICU beds. You can imagine in a population of 30 million. And there are less than 500 ventilators, which as of 7/19, when I was preparing this, were full. Nepal's economy is really agriculture and tourism based, and 30% of GDP actually comes from remittance. And we'll discuss why this was important in terms of COVID as we go forward. As far as COVID goes, the first case was identified back in January 24th, and it was a person who had come from abroad. So by March 14th, there was suspension of all travel on tourist visa. And this is really important timeline because Nepal being very dependent on tourism, this is the highest time for tourists sort of going to Nepal, like around March, April, May. And March 23rd, second case was identified, and then the next day, the country went into countrywide lockdown. May 16th was the first death, and by June 9th, reopening plan has been started, and I think as of yesterday, August 15th is the day they're going to open the whole country back up. And so far, we've had more than 18,000 cases, and now the number of deaths is actually 42 as of today. And this is just a curve here. You can see that there's a sort of a spike in cases after May 22nd. And this actually has a lot to do with, the first thing we'll talk about is the utilization of RDT testing in the diagnosis at the early phase. And this spike is seen after the PCR test was prioritized a little bit more. So what we'll do is I'm just going to talk about a few challenges and the unique kind of situations that Nepal saw since COVID-19 outbreak started there. So number one is really just going along with Dr. Gronvall's topic here, initial focus of the country on the RDT testing as far as diagnosis goes. And we just learned that at a population level, this, the serology test can be useful, but at an individual level, the utility is actually for diagnosis. It's very minimal for acute diagnosis of COVID-19. So it was not until May 11th, and if we go back to that curve here, it was not until when the PCR testing was actually prioritized we started seeing infection uptick in the country. By July 20th, we have had a significant rise in PCR testing, but the lack of, since January till mid-May, the leadership and government bodies have not really prioritized the right type of test for diagnosis, and this caused massive protests around the country there were rumors of taking kickbacks, corruption, and all that stuff that goes on with this. And interestingly, the protests that were rising actually happened to correlate with the Black Lives Movement protests that are happening in the U.S. and around the world. So maybe some influence there. But these are some pictures of the protest of youth taking the streets. Fortunately, they were practicing social distancing here in some cases, but some of these did turn violent. And just some headlines of Nepal focusing on the wrong, unreliable test. And there were a lot of concerns that these tests are coming from companies that had not tested this test and have been refused, by countries like the U.S. that have the FDA to actually, look at things that are being done. There is no sort of body that's looking at what is good and what is not good in the country, and sort of any test is being utilized, and we really don't know how good the test is. So that was a major challenge so far. I think it's improving now with the rise of PCR testing. Another unique challenge to the country is its migrant workers. As I said earlier, Nepal is a fairly young country, but a lot of those youth have gone to Gulf countries, especially Qatar, Dubai, Malaysia, for economic opportunities. And it's actually the fourth most remittance dependent economy in the world. Major concern with this countries and the companies that take the workers is that they keep their passports, and the conditions are very harsh. And when COVID happened, the response from these companies was not to keep these workers safe, as we can imagine. So there were a lot of migrants that were wanting to come back to the country, and the Nepali government sort of struggled to really bring its citizen back to its country. There are stories of migrants being stranded along the India border and outside the airport for many, many days. And the quarantine facilities that were created for these migrants also were widely mismanaged in the initial part of this COVID response, which ultimately ended up causing some of these returnees to spread into rural areas without proper screening, and that probably increased the prevalence of COVID in the country. So this is a picture of this is one of the borders along the Nepal-India border, and these are the workers who used to work in India that are trying to return to the country. And that struggle actually, I think, so far, as of a few days ago, only about 10,000 migrants have been brought back, and there are more than 1 million outside. So that's an ongoing challenge. And finally, Nepal has it's a small country, but the health system in Nepal is very weak, and there is a significant lack of necessary training even before COVID in disaster response and things like that. So the physician ratio is very low, as I mentioned. The ventilator capacity has filled. There is a big gap in private and public institutions. So Nepal is run by a lot of trusted health institutions happen to be private. But in the initial COVID phase, these hospitals were refusing to see patients, especially COVID patients, and also locking their doors because there was not enough support coming from the government bodies regarding PPEs, training, and things like that. And especially in a country where there are 80% of people live in rural areas, the rural health post and rural health centers were sort of left, and they, in many cases, they still are left on their own to figure out how to triage, where to put the patient if they are a patient of interest for COVID. So specific training regarding how to respond in a smaller health center has been really missing. Now, there are some bright side. I saw someone put in a Don put in a comment here that Nepal's death rate is low. Absolutely. So there are some good things here. It's a young population with average age of 24 to 25. And that's very different demographic profile than Italy or US, where mortality is a little bit higher. And this likely can be attributed to age as well. Case fatality rate so far is less than 0.3%. In cities like Kathmandu, where already there was dust and pollution prior to COVID, people used to wear masks going out. I certainly have in Kathmandu before COVID, so I think this has sort of mask adherence is not, I think, as big of an issue in Nepal as it is in the United States. The travel ban was quite early, and they stopped any tourists from coming in, which I think has proven fruitful. Rural areas tend to be better for physical distancing, just given the just widespread housing and not congested areas. So that is probably attributing as well. There has been support from the World Bank pledged to 27 million in COVID response for the Ministry of Health and Population of the country. And now, as I said, PCR testing have been increasing, and I think our focus on individual diagnosis using RDT has been sort of dying down and lowering in the country, which is a really good thing. One really a good strategy that the Ministry of Health has been promoting is just communication and risk communication. So they have a daily communication briefing, which actually has been very beneficial, and then creating of a phased reopening of the country instead of just opening everything all at once. So these are some of the good things that Nepal has been able to do. Now, I just want to briefly mention the organization that I've been working with, called HAPSA, which is an organization that I founded back in 2012. And in the context of COVID, our work has been with hand washing and public health awareness from a long time ago. And this has really, found its utility during COVID time. So we've been able to make a lot of videos to promote in the national media as ads in the radios regarding masks and how to take off a mask, making your own mask at home, hand washing. Especially, we have a 20-second really catchy song in Nepali and that we've been promoting. Gloves and really should we use them? And then we also do live Q&A with special focus on rural areas. I think a lot of Facebook events and news events tend to focus on economic centers, but Nepal is uniquely rural, so we wanted to focus on that as well. And then we've also had hotlines of public health workers and doctors available for people to call regarding any questions that they might have. Here's just some snippets of our campaign and kind of our reach, which is, through Facebook, we've been able to reach quite a bit, and also through national media. And we created this hand washing challenge. That's just a 20-second challenge with a Nepali hand washing song. So the key points with Nepal, a very beautiful and small country. I think the initial focus on the wrong test and really focusing on the RDT testing and serology for diagnosis really set back our country by a few months. And this is probably due to mismanagement, corruption, all those things combined, but now going in the right direction. And Nepal's context with the migrant workers as well as a rural majority and the weak infrastructure did present with some unique challenges in COVID response. And again, I think the rural areas and young population generally will likely help keep the mortality low in the country. That's about it. If I can provide references at request, and I look forward to answering any questions you might have, and you can visit all our organization's pages here. Thank you so much.
Thank you, Dr. Kharel. I will not ask you to sing the song right now, but maybe later, if we have time, we can. I've heard it personally, and it's really very catchy. So well done. Please stay online with us because we are going to turn it over now to Dr. Wax for the Q&A, and I will come back to you with some questions about your presentation. Thank you.
And thank you very much to both presenters for two excellent presentations. So, Dr. Gronvall, I'd like to start off with a few questions. You know, one of the essential issues which you touched upon is you know, the difference between the population and the individual interpretation of these antibody tests, and specifically the impact of the prevalence of the disease in the testing population when it's a very low prevalence versus a higher prevalence. Could you perhaps discuss that one more time with an example of why in the setting of a low prevalence, you know, there would be much more likely to be a result for an individual that would be potentially misleading versus if there's a higher prevalence of the disease, that false negative rate, the false positive rate will actually be lower.
Sure. Although I have to tell you, it's a lot easier to look at if you're, there are some tools that I can share with you that are available for clinicians to be able to do the statistics, and so you can figure this out for your area. It really comes down to just the amount of negative people who are in your population, and if you have a certain percentage of false positives, that it becomes much more dominant as a result. It's hard to. It's not being a statistics professor. It's kind of my. It's just easier to see. I think I had it on one of the slides. If you want to scroll back to it.
Yeah, if you scroll back 20 slides, we can take a look at that.
Because you're right, it really makes no sense when you're thinking about it like the way that you, you know, the way that you go through life. Like it's you know, you either have the antibodies or you don't, right? Okay, yes.
Go forward 3 slides. Right
yeah.
there. Oops. Okay.
So here you have just looking at a population of 1 million people, estimating 15% of them infected, and you have a test where 5%, you're expecting 5% false positives, 5% false negatives, and that you know, that's what you get. It comes out to a lot of false positives. And if you think, for just even if it was just this, and you didn't have the influence of the seroprevalence, what people are doing as a result of getting that test. So, I mean, I think FDA underestimated the amount of consumer demand that there was for these tests, and they were focused on the diagnosis of disease and contact tracing, but there's a huge consumer demand because people wanted to be able to take off the mask and to see their grandparents and to, you know, do all these things that they were not doing. And you mentioned you were disappointed that you didn't have antibodies. We'll get to that in a second. But all these people who were getting the test, getting a false positive, then, you know, thinking that they're in the clear and they're not. The false negatives are less of a problem for public health generally. But it just works out that when you have that the false positive is magnified when the disease is of low prevalence, and that's why for HIV you don't just get the one test. If you get a positive result in the first test, you go through and take several tests to make sure to bring the statistics up. But you mentioned that antibodies might not always be awesome. Like the Department of Defense almost immediately put out a policy proposal that they were not going to allow recruitment of people who had COVID. So they backed off from that. But you know, one thing that we're concerned about in the future is employment discrimination based on this. If it turns out that people have long-term medical sequelae that are going to be complicated and an employer might be on the hook for, I think this is going to be a more serious issue going forward. So, you know, it's not always, it's best to not get the disease if you can.
Okay. Another question about cross-reactivity with any of the other coronaviruses. Of course, with the common cold, coronavirus is one of the viruses that does cause that condition. Is there the possibility of cross-reactivity with other more common coronaviruses?
The tests, no, they're significantly different. So the antibody tests that are on, that at least the ones that have EU emergency use authorization, they're not cross-reactive with either SARS-1 from 2004 or other common cold coronaviruses. What's interesting is that the T-cell data, which is a lot more complicated to figure out what's going on there, it looks like there is some protection that some people, or some T-cell responses that might indicate protection for people who were exposed to SARS in 2004 or had exposure to some other animal coronaviruses. It doesn't look like there's much T-cell responses in to common cold varieties. So it might be that this is just another complex part of what makes some people more immune than others or have more severe effects of COVID, that they may have some background of being exposed to another animal coronavirus.
Okay, great. Thank you. Another question. Some weeks ago, there were reports of both some CDC data as well as some other, I believe, State Department data was actually combining both the PCR and the antibody tests. What would be the rationale to combine those tests together?
There's no good ration. There's no public health based or scientifically based rationale for doing that. One could imagine that one could put them together in a way that would be, politically helpful. Because look at all these tests that we've done. Wow, it's just amazing. So you can imagine that. You can also imagine that maybe people just didn't realize that they were doing that and that was not the best practice. But it's not best practice. It shouldn't be done, and that's a problem. And also, I was originally, but there was a lot of places that were saying, oh, well, the data, they just didn't get separated out. But at least in the CDC reporting form, they are separate when they hit CDC. So I can't explain it.
Okay, good. Thank you. Another question. In New York, which was particularly hard hit, as we all know, in late March and April, after the worst of it, the incidence of new infections has dropped dramatically and remained relatively low. With some sero testing in some of the communities, particularly like in the Elmhurst area and whatnot, the seroprevalence rate may be as high as 30%, 35%, at least in some preliminary studies. Is the low incidence of new infections at all attributed to the potential of herd immunity in those particular communities, or is herd immunity only to be found at a higher seroprevalence rate?
Right. So that was one of the studies that made us motivated us to write a best practices guide for sero surveys and to try and make it understandable for reporters who are evaluating these very complicated sero surveys. That New York study was interesting, but one of the things that was wrong with it is that they only tested grocery store employees or people who are involved in probably had higher exposure than if they did a truly random population study. So that's one thing. But as far as herd immunity goes, the estimates that people have made about what it would take to reach herd immunity for SARS-CoV-2 is is on the order of about 70% exposure. So because of the degree of asymptomatic infections and the transmissibility, it's a little bit on the higher side, and we're nowhere near that. I think it's best to think of herd immunity as something that we need to deal with when we have a vaccine or multiple vaccines, and to make sure that we get the coverage of vaccination to equal 70% or more, which is going to be challenging enough when I see the effect of the anti-vaccine campaigns every day. You open social media, and it's a horror show when it comes to the misinformation about vaccines. So that's going to be challenging enough to get to herd immunity in that aspect.
So just to follow that, if you had several different scenarios, one where the seroprevalence is 5% versus 25% versus 50% versus 70%, does the transmission decrease at 25 and 50%, or is it really only something that has an impact on transmission once you get up to the 70%?
Yeah, unfortunately, I'm not a modeler, and so what you're saying makes sense. It would not be a straight line, but there would be some sort of curve there. But I don't know. Okay, great, thank you.
Okay, another question. One of the listeners says he's in primary care and he gets constant requests for antibody testing, and he doesn't have the capacity for all of them. How can he determine how to triage, who should have antibody testing and who may not absolutely need the testing?
I mean, the kind of uncomfortable answer is that really nobody needs it. And because, what is it that you're going to change as a result of the antibody test? Are you going to stop wearing a mask? Are you going to stop taking precautions when you go places? Or are you going to stop washing your hands? It's really, but it's an uncomfortable thing, because you're right. A lot of people have a very strong personal desire to learn this piece of information, and it's very frustrating. So I think there is a value in when it comes to people who are at higher risk to know if they've already been exposed. But I worry about those people who may be at higher risk, like if they work in particularly like in a healthcare setting or in a nursing home setting. For those people, it might make sense to have sequential testing and really get to the bottom of whether or not they've already had it. But nonetheless, because we don't know about the degradation of antibodies, whether their immunity will wane over time, if it turns out they think they're protected and they're not, and then they expose lots of people, that's not good either. So it's very complicated, and but I get, even in my own center, a lot of pushback when I say, well, it's really just personal curiosity that people want to know about their history, and they're like, it's not personal curiosity, I just really want to know. I'm like, well, that's kind of personal curiosity, but it's a fraught topic, and I'm sensitive to people's real desire to know, but at this point we have no behavior that should be changing as a result of getting the test or not.
Okay, great, thank you. Question about the difference between the degree of neutralizing antibodies and what is built up with vaccination. Does one interpret them differently?
So far, what we know about neutralizing antibodies is that they correlate with the antibody. So if you get an antibody test and analyze the test, you measure a certain amount of antibodies. That measures just the antibodies that you have. It doesn't measure the neutralizing ones, but for other studies have correlated neutralizing antibodies to the total. So it looks like people who have had more severe disease have more neutralizing antibodies. On the other hand, people who have had mild or severe disease, it doesn't seem to affect their T cell responses. So it's still, the picture is still being worked out. But it looks like neutralizing antibodies correlate with their overall antibody levels.
Okay, great. Thank you. So reported daily is the number of positive cases by PCR. Are there databases of reports of seropositivity, and are those publicly available by region or state or local jurisdiction?
I believe that is a tab on the Hopkins dashboard as far as the information we have. I believe that is one of the things that you can search.
Okay.
But I don't know.
Okay, great. Thank you. And I think at this point, I'll turn it back over to Dr. Kazi for some additional questions.
Thank you, Dr. Wax. My question is a little bit more from a public health perspective. If a government or a community is considering a serology test, a serosurvey, of the three methods that you described, the RDT that was used in Nepal, the ELISA, or the neutralization assay, which one would be the most reliable in terms of the validation issue that you pointed out? You mentioned that there are over 200 tests in the market. Mm-hmm. Is one of these three worse than the other, or is ELISA better, for example?
I think an ELISA is where most of the tests are going, or some ELISA, permutation. The RDTs have much more value as a testing strategy for on the diagnosis side. So rapid antigen tests are are very cool to have available. That it's fast, it's quick. You get answers really. It's not as sensitive, but that's it's better than nothing. For if you're doing a serosurvey, ELISA is the way to go. And of course, the more you can do to capture like PBMCs, to capture cells, so that you can do tests in the future, it's important because I know we're definitely in crisis mode here, but we have to think there's going to be a time 10 years from now, like there will be still COVID research going on where we're going to want to know, we're going to have questions about these early days and these cases and what we can learn from them, because it looks like already we're seeing some unexpected different medical issues that are popping up. And so to be able to address those questions, we need to have these long-term cohort studies and collecting all the information we can for them.
Very good. I have two last questions. The first one is regarding antigen testing. Can you comment on antigen testing, or is this something that's not in your area of expertise?
Sure.
At all?
Yeah, happy to talk about antigen testing. It's kind of amazing. A lot of countries are testing everybody that comes off of a plane. I found that I just heard that they're doing that in Athens. Just to everybody's getting. I think more testing is good, and having more people bumping into testing is great to keep case counts low.
My last question to you. When we develop the vaccine and try to look for the neutralizing antibodies, are we going to face the same problem we are facing right now with these serology tests, validation, and dependence on prevalence, etc.?
When it comes to doing these studies, doing antibody tests regarding when we're trying to prioritize vaccines.
No, I apologize. No, I meant the vaccine research. When we do our studies on the vaccines, and we will be measuring neutralizing antibodies in the subjects and controls, right. Would we have the same problem, or is that different technology that is better developed at this point, better validated?
I think that there's going to be a lot more. There already is a lot more regulatory control over vaccine development, and so. The issue here was like, oh, it's just a research tool, so fine, you can market these tests. But it wasn't just a research tool. It was a test that was in high consumer demand, and so a lot of consumers spent a lot of money on junk. And so and so Congress got involved. They've had hearings on this, and that's probably going to continue. When it comes to vaccines, it's everybody. There's going to be a lot more in-depth studies, and I don't think that this is going to be an issue. I do worry that it might become important to know if somebody had COVID before for some of the vaccine candidates, and so I think some of these issues of making sure you have a highly accurate test and maybe doing sequential testing might become important for one vaccine candidate or another.
Very good. Thank you so much. Dr. Kharel, I have a few questions for you as well, if you don't mind unmuting. My first question is about remittance. You mentioned the word remittance, and I had to look it up. Do you mind explaining what that means to some of our participants that may not be familiar with the term?
Yes, absolutely. So it's basically the money, in simple, it's the money that comes to the country from the workers that are working abroad. From the country, so it's just goods or money that are going to go back to Nepal. So, for example, my parents send money to my relatives for things that they might need, who are in remote villages who might need money. So the amount of money that actually goes back to the country from people who are working abroad, that's the remittance.
And how do you see the public balancing a case fatality rate of 0.22% with a significant economic toll because of the tourism and the loss of remittance?
Yeah, I think that's a very interesting thing, and a lot of people in Nepal, they're like, oh yeah, we're high in mountains and we eat all this food, so we are immune from death, from COVID. It's like all this information, that's sort of misinformation that's been spreading, and it's really hard to give. I think it's really hard to come up with the answer of why exactly in some countries mortality is lower than others, because we don't have like proof of, oh, is it the, I don't know, there was a question of BCG vaccine being a player in that. But I think so far, just looking at some countries with higher mortality, I think the younger population, we know that higher older population has a higher mortality. So it is a younger country. So definitely, I think that's attributing. And another thing likely is just a spatial nature of rural areas that might be helping keeping the, so far the infection number is about 18,000 when it was not really that well controlled in the initial, just public health measures were not really well applied in the initial bump of COVID. So I would expect those numbers to be higher, but maybe that's due to testing, or maybe it's, it's not spreading as fast due to just the spatial nature of rural areas.
And have there been any experience with the rural healthcare system reaching capacity, or is everyone being transferred to the the central healthcare systems?
Yeah, so a real issue has been around the border regions with. So Nepal is Nepal's in the Nepal southern border is India, and a lot of the cases that have been positive in Nepal have actually been the people that have been coming in from the borders, and those rural areas are having really difficult time managing the facilities and taking care of patients. And unfortunately, especially in the initial part, there was like no training to the ambulance drivers. There were no protocols made. So one of the first deaths in the country that was very known. It's only a country of 42 total deaths. So there's a story with every single death. And one of the first deaths was this patient who got COVID, but also had diarrhea and was just dehydrated, and the ambulance refused to take him to a health facility that was in a city. And that's due to just the lack of training and equipment that's available for these people to be able to transfer them. So the rural areas have been really hit hard just because they just don't. They're just making things as they're coming without a lot of capacity building that was done throughout.
Someone from our participants just sent another question about the attitude of Nepalese regarding vaccination. Can you comment on that?
Oh, Nepali people will take a vaccine if there like there is the anti-vaccine movement does not exist as much. I mean, it's a very Nepali people are it's just the availability. I think because of low research. You know, I tell them, you know, whenever a Nepali person asks me, oh, when will we get vaccine in our country? I'm like, you know, things like PPEs and things like that should be easily available will take so much longer to get into our country because we're one poor country, right? So vaccines, even if created, will go to rich countries and people with resources first. So even if like it gets created in like, you know, let's say 12 months, it's not going to get to Nepal, I feel like, till much later. But overall attitude is, oh, we want vaccine, if there is one.
And can you comment on the rate of obesity and diabetes in Nepal?
It's definitely rising over the last, 10, 15 years with a more westernization of food and that. But it's the rural people are actually tend to be generally healthier and life expectancy tends to be higher in the rural areas. But definitely diabetes and hypertension are on the rise in the last 10 to 15 years in the country.
Do you think the earthquake has had significant impacts that are still felt until today, affecting the response?
Absolutely. The earthquake just caused for people who might not know, there was a massive earthquake in Nepal in 2015, which killed almost 10,000 people, but it really just damaged the infrastructure of many healthcare settings in rural areas, as well as houses, toilets, things like that. And it has taken, I think this overall management by the earthquake response body in the government has been really, really slow. I mean, as a organization, like as HAPSA, an organization that individuals started, we were able to build more health posts than the government was able to in 4 years. So, you know, it's really sad, just the mismanagement, although there was so much money. I think finally we have a earthquake task force that is now, giving money, helping rebuild some of the houses, and that has been kind of the rate of that has been rising in the last 2 years, but it took a while for that. And definitely there are people in the country who are still seeing the aftermath or feeling the aftermath of the earthquake.
Thank you so much, Dr. Kharel. Please send on Twitter the link to your song on hand washing. I think our viewers may want to go on Twitter and look it up. Thank you again for taking the time, and best wishes with your excellent work in Nepal. I will turn it over now, Dr. Wax, for maybe one or two last questions and closure. Thank you.
Thank you, Dr. Ziad, and thanks to both of our speakers for an excellent Q&A. I have two final questions for Dr. Gronvall. One of them is actually about the antigen test in terms of returning to work. So some folks have been up against a new policy now that you have to have several COVID negative tests, and then you can return to work as someone who's no longer transmissible, no longer infected. What do you think about that sort of approach?
I think the way Hopkins is doing is a certain amount of time post the onset of symptoms or post that positive test. So not having testing be the trigger to go back to work. That the initial test was sufficient. And the same goes for isolation. So the reason being is that these tests are not, they're not telling you have infectious virus. That would be a maybe in the 100 years in that pandemic, they'll have that easily available test to determine that. What it's telling is that it's finding pieces of the virus, whether it's PCR test finding pieces of genetic material or the rapid antigen test finding pieces of the, the outside of the virus. So it's not telling you that you're infectious. And so people have had lingering positive tests that are not indicating that you're still infectious. So that's why at least Hopkins and a lot of other places have moved to not making testing as a trigger to go back.
Okay, thank you. The last question I've already addressed, but does a positive antibody test mean that the person who has the positive test cannot transmit the virus to others?
Yeah, so this is a big unknown, right? Because, at least from SARS-1 data, people, it's really hard because to know, because that virus, thankfully was, that epidemic was stopped and there are no longer circulating cases. But it is possible that there is some in-between effect where somebody is immune or they have a very limited infection, or that they have like a just a very limited or asymptomatic infection, but still are producing virus. And we just don't have that observational data to be able to say. Certainly when it comes to our experience with vaccines, we know that people who have a little bit of immunity but not enough of immunity are still able to get infected, and maybe not as bad as if they had no immunity, but they're still able to transmit disease. So we see all kinds of things in immunology, and we just don't know what the answer is for SARS-CoV-2.
Okay, great. Thank you. Well, I'd like to thank both of you again very much for speaking to us today. I think the antibody talk provided us with some very grounded scientific advice that antibody test perhaps is not what we all had hoped for, but I think that is good advice to both healthcare providers and the public at large, that it's not a cure-all in terms of moving forward. So again, thank you very much to both speakers. If we could go to our next slide. Again, this webinar has been recorded. It will be posted onto our website by Friday. You'll be receiving notification of that, as well as future webinar events. Next slide. And next week, we have another very timely talk. It's on school reopenings, clearly a topic on everyone's tip of their tongue. Claire Barnett, who's founder and executive director of the Healthy Schools Network, will be giving a talk about this critically important subject, as well as Alan Burkham, who's an industrial hygienist, will discuss some of the industrial hygiene issues in the school environment. So that's next Wednesday on July 29th, 2020. Look for an upcoming announcement regarding that event so you can register. Thank you very much and have a good day.